So welcome. Look, so we are now a few months before GIEQs VI, and one of the real clear messages we want to get across in this symposium is how to do high quality gastroscopy. Gastroscopy in addition to colonoscopy, but we are now more focused on gastroscopy, and we've got these big conditions where we're saying that the risk during gastroscopy of finding something, early cancer, or missing an early cancer is higher. Barrett's esophagus is one of those. So here's a Barrett's esophagus case you see on the screen. Let's talk about, quickly, a couple of minutes, about Barrett's esophagus assessment. So an overview is really important. Let's try it. So what we want to do is we want to insufflate a bit. And this is best case scenario because the patient is well sedated. Sedation is critically important for upper GI endoscopy, particularly in the situation where you suspect, as in a patient with maybe relatively long segment Barrett's esophagus, that there's a problem. And you want an overview, right? This is not a bad overview. It's a little bit blurry. We get the idea that we can see in the distance, we can see the gastric folds. We can see that there's been some biopsies taken, these areas of squamous mucosa within the Barrett's. And we can see that this is not a circumferential Barrett's. This is actually quite a short Barrett's esophagus segment, but in which somebody previously, in this case, has found dysplasia on a biopsy. So if you're starting for the first time, you have an overview, you get in your head, okay, I can see something, I can see nothing. Here it's not so super obvious that there's any problem. And then we have a little look more closely with white light. So we're going to get using a cap I think is critical so that you can splay open the gastroesophageal junction, come up a little bit, and now we can see that area nicely. You can see quite a bit of nodular mucosa here. It doesn't seem to have any kind of aberrant structure, and we're going to come back slowly. You can do a little gentle movement around to get a really good view of everything here, to give yourself the idea that we don't see something jumping out at us. And you can use the cap to push up, you can use the cap to get on fast with things which you otherwise couldn't. And if you don't have magnification, this is what you might see. If you want to use magnification, because you have it on the endoscope you're using, like this one, and I'm using the first step of many, maybe equivalent to a near focus mode in another provider, then we can already push around and do this. But actually what might be more interesting is to use virtual chromoendoscopy, in this case BLI. So starting again here, we got that one zoom on just so that we can get a nice overview of the microstructure. This microstructure maybe looks a little interesting, a little bit different from the rest, a little bit more open, the pattern here. And as we come around, we get the idea. But of course, we understand the fact that probably the step one, which I just described, is what most people are doing because their sedation is not as perfect as this, for example, or they don't have experience using virtual chromoendoscopy like I'm doing here. So then maybe the better step is to say, well, okay, I'm going to use my white light endoscopy without magnification, and instead I'm just going to do some acetic acid down the channel. So it's something you have to be familiar with in your department. You have to have it there. It doesn't matter, I think, where you put it. You're trying to suck the mucosa. It's a little bit difficult here. I want to put it down here, force it down. I have a syringe, or force it down. It has some air behind it. And we want to get coverage of the mucosa. And then we want to suction things closed a bit, right? So that we're going to get coverage. So we put it down there, and we do suction to get it to cover the mucosa. And then we take an overview. So really, there have been some very nice demonstrations of this during the GIEQs Symposium over the years. A very nice one by Pradeep Bhandari last year, I thought, on assessment of Barrett's. And he was making the point that you've got 20 to 40 seconds that you need to wait for this technique to work. So we'll wait that time. Lens is a little bit dirty in the time. If you wanted to, you could go and clean that. Maybe we'll take the time to clean the lens while we're waiting for this to happen. But we won't take our eyes off the ball here because what you're really looking for is in your overview an area of loss of acetylweining. So we'll use 10-second pit stop. Always important to make sure the endoscope you're using. Another feature of this symposium, we'll be talking a lot about which endoscope you're using and why. In this case, I'm using a high-definition endoscope with zoom capability because we know that we have a chance of having a precursor of esophageal cancer in this patient. In this case, a very increased risk because somebody took a biopsy showing something previously. But in the case of, for example, a long segment Barrett's esophagus, circular, maybe of more than 10 centimeters, you need to be looking carefully. And so here, we don't see anything. We don't see ELOR. early loss of acetic winding, which is the most important thing that you're looking for when you're looking for dysplasia within Barrett's esophagus. And even if you don't know anything about vascular pattern or pit pattern or microstructure or anything, you can put this on and you can get a good idea if there's a serious problem just because part of this goes red or loses its whiteness, we should say, more quickly. And so here we don't see something. And actually, maybe you could say, well, in this area here, and this is now, I'm cheating because this is actually the area where the biopsies were taken, which showed something. So if we look more closely in white light, we see some loss of uptake of the acetic acid or early loss of acetic winding. And we also see, looking on the microstructure, that it's maybe not completely regular. But this is way beyond what the expectation is for standard gastroscopy. The standard approach probably to these patients should be that if patients have Barrett's esophagus with either long segment or known dysplasia, they should be on a separate list with someone who has an interest in this, who understands virtual chromoendoscopy, who understands how to use it, who understands how to take focal biopsies, and who has a connection with an endoscopist who works in an MDT, who further can manage any lesions which were found. So I hope this was useful. This is an overview of how you might apply acetic acid and how you might use it. And if you want to have a look on GIEQs, there are many, many examples of abnormalities. And in addition, you should come to the symposium where we're going to discuss all this in much more detail. Look forward to seeing you there.